placental abruption. While in the postpartum, you have the 4 T's, that is uterine atony, retained placenta, uterine rupture, and coagulopathy. That is, you have the tone, tissue, trauma, and thrombosis, which are associated with the obstetric hemorrhage. Now we come to the most important cause, that is the placental abruption. Abruption is due to disruption of the union between the placenta and the endometrial lining. A number of causes have been postulated, most important risk factor being preeclampsia. Patient may present with abdominal pain and vaginal bleeding, which can be concealed or revealed. If it is revealed, it will be a profuse vaginal bleeding, or it may be a concealed one with a retroplacental blood clot, in which case the patient may present with hypotension in the absence of vaginal bleeding. Associated with this, there may be uterine tenderness, uterine irritability. A coagulopathy may be present. Patient may present with preterm labor and a non-assuring fetal heartbeat. Now, placental abruption is known for its complications like hemorrhagic shock, disseminated intravascular coagulation, which occurs in about 20% of the cases, and it is mainly due to the release of thromboplastin. This thromboplastin can lead to the genesis of thrombin, which leads to conversion of fibrinogen to fibrin. And this can cause a disseminated intravascular coagulation or a consumptive coagulopathy. So there is consumption of a number of factors like factor 1, factor 5, factor 8, which all can lead to a torrential bleeding. Patient may present with acute renal failure. Due to the presence of fibrin split products, there could be uterine atony, and this may precipitate a fetal distress or demise. Now, the laboratory findings, because of the associated disseminated intravascular coagulation and coagulation abnormalities, these findings may be abnormal. Prothrombin time could be prolonged. The partial thromboplastin time could be prolonged. Prothrombin time may be elevated. Fibrin split products may be increased. Thrombocytopenia and hypofibrinogenemia may be present. This may be evidenced by an thromboelastography, in which the K time, which is normally 2 to 5 minutes, may be increased, and there is a decrease in the alpha angle, which is normally about 50 to 70 degrees. Now, the obstetric management will depend upon whether the fetus is live and viable, and whether the condition of the fetus. If the fetus is live and viable and there is a non-reassuring fetal heart, patient may be posted for an emergency LSCS. So there are certain prerequisites to be followed when taking up these patients for surgery. 2 large bore IV access should be present. Packed RBCs, if available, should be taken from the blood bank. Volume resuscitation using non-dextrose solutions, left uterine displacement, urinary catheterization, and oxygen therapy based on the pulse oximetry. Anesthetic techniques may be guided by the necessity for delivery of the fetus, by the degree of placental abrasion. If the patient is hemodynamically stable and the maternal and fetal consequences are not much, a neuraxial technique with continuous epidural for labor and analgesia and vaginal delivery can be considered. However, in most cases, because of coagulopathy, because of maternal instability, and hypovolemia, an ongoing hemorrhage, a general anesthesia, which is a rapid sequence induction, and intubation may be necessitated with cricoid pressure. Induction in these patients with propofol and thiopentone may be contraindicated due to the hemodynamic instability. However, etomidate and ketamine are good choices, but ketamine in a dose of more than 1 milligram may again produce a hypertonic uterus. So etomidate may be the choice for induction in these patients. And once the baby is delivered, then the bleeding can be controlled with your pharmacological methods. Next, we come to the another important factor, which is placenta previa. This is an abnormally implanted placenta where the implantation is ahead of the fetal presenting part. And depending upon the level of implantation, they may be classified as low-lying, marginal, partial, or total. Low-lying when the placenta occupies the lower uterine segment. Marginal when it lies in close proximity to the lower uterine, to the internal os. And partial when it partly occludes the internal os, while in total, there is complete closure of the internal os by the placenta. This patient is diagnosed by a painless vaginal bleeding. This is in contrast to the abruption where there is pain and the uterine tonus may be increased. But there is an association with abruption in 10% of the patients. An accurate diagnosis of placenta previa can be made by an ultrasound in contrast to an abruption, which is a clinical diagnosis mostly. Now, preparing this patient involves airway assessment, assessment of blood loss, and simultaneously, as in the case of abruption, wide bore IV access with volume resuscitation may be required. Choice of anesthetic will depend upon the indication and urgency of delivery, the severity of maternal hypovolemia, and previous obstetric history. Now, patients with placenta previa can be grouped into two classes. One, with those without bleeding, where the intravascular volume deficit may not be present. In these patients, a neuraxial block can be given. Even in these patients, caution should be exercised during the intraoperative period because there is an increased risk of blood loss because the obstetrician may cut through an anteriorly located placenta, or the lower uterine segment implantation site may not contract well after the delivery. And in those with a history of previous LSCS, there is an increased risk of placenta accreta. So these patients should be carefully monitored during the intraoperative period for fresh bleeding or the other hemodynamic disturbances. Patients with active bleeding, they require a more careful attention with special instruments like rapid infusers, warm fluid warmers. Invasive blood pressure monitoring should be instituted, central venous pressure monitoring, blood transfusion tests, and even sometimes, even before the start of surgery, type-specific blood, or if that is not available, an O-negative blood may have to be given to these patients. As in the case of an abruption, a rapid sequence induction may have to be followed with special emphasis on hemodynamic monitoring. Soon after delivery of the baby, oxytocin in a dose of 20 to 40 units may have to be given as an infusion to control the hemorrhage. Next, we come to a very important identity, that is the placenta accreta spectrum. This placenta accreta spectrum is known for its torrential hemorrhage during the postpartum period. This is an abnormally adherent placenta. There are three types, the placenta accreta vera, where there is a direct adhesion of the placenta to the myometrium without an intervening decidua. In placenta increta, there is invasion of the placenta into the myometrium. And in percreta, it invades the myometrium and the serosa and sometimes into the adjacent structures like the bladder. And if it goes into the bladder and patient complains of pain, abdominal pain, then one should suspect a uterine rupture. Now, there are certain specific risk factors for this PAS. This includes previous CS, presence of placenta previa. Even a uterine surgery like myomectomy can predispose the patients to an adherent placenta. And assisted reproductive technologies like in vitro fertilization, embryo transfer are all predisposing factors for a placenta accreta spectrum. Clinical features, patients may with associated placenta previa and accreta may present with antepartum hemorrhage. And as it has been said from many epidemiological studies that 50 to 60% of placenta accreta spectrum are undiagnosed antenatally. And the first indication may be a massive hemorrhage during the operative period when a manual removal of the placenta is attempted. So, an invaluable tool is an antenatal obstetric UST, which helps to localize the placenta and also tells you about the type of placenta that is present. Now, what are the common findings in a UST? There may be multiple placental vascular lacunae, which is greater than 1 centimeter. Normally, there is a clear zone between the myometrium and placenta. This clear zone may be lost, or the myometrial thickness overlying the placenta may be decreased. There could be an abnormal vascularity, there could be a placental bulge or exophytic mass. All these indicate extension of the placenta into the myometrium serosa or the bladder. Now, this UST is not without limitations. So in certain cases, an MRI may be needed to confirm your diagnosis. In the MRI, uterus may be seen as an abnormal bulge into the bladder. Sometimes the zone between the placenta and the uterus may show focal interruptions. There could be abnormalities or disorganization of the placental vascularity. So all these red flag signs should be known or should be assessed by an anesthesiologist prior to taking up the patient for surgery so that we can adequately prepare for the procedure. These patients in whom we suspect a placenta accreta are prone for a torrential hemorrhage during the intraoperative period. And this should always be kept in mind while anesthetizing these patients. And depending upon the ultrasound findings and the MRI, patients are graded as those with high suspicion for a placenta accreta spectrum or those in low suspicion. So those in high suspicion should be specifically monitored and blood products should be available to counteract the hemorrhagic episode. There is the standard plan for delivery with known PAS is a planned cesarean section with a contingency plan for emergency delivery. And optimum timing is individualized, taking into account the advantage for the fetus and the maternal advantages. And usually it is at 34 weeks of gestation. And an early multidisciplinary team approach consisting of an anesthesiologist, a senior gynecologist, interventional radiologist, and blood bank facilities should be available in the immediate vicinity when such surgery is being planned. Now, the obstetric management in these patients may be classified into two major groups. One is a conservative and the other is the non-conservative. Non-conservative implies, which is the universally acknowledged approach in a case of placenta accreta syndrome, is a cesarean hysterectomy. While in a conservative approach is usually kept only for those patients who are hemodynamically stable and in whom fertility needs to be maintained for the future. Intraoperatively, some centers, you have the facility to do an ultrasound so as to confirm the placental position prior to uterine incision. This is important because if the incision falls onto the placenta, the baby can exsanguinate and fetal demise can result. Now, conservative management falls into three categories. One is a uterine preservation with placental removal. But this is only practiced for partial placenta accreta or where there is small focal areas of fundal invasion. Here, the uterus is preserved with placenta removal of the placenta. There is an expectant approach in which the intact placenta is left undisturbed and the uterus and abdomen is closed, waiting for spontaneous placental involution. But this carries a lot of risk in the form of delayed hemorrhage, infection, which can follow this procedure. Then you have the triple P maneuver, which is perioperative localization of the placenta, pelvic devascularization, and placental non-separation with excision of the myometrium, followed by restoration of the myometrium. Now, devascularization of the pelvis is carried out after the fetus is delivered. That is, a pre-positioned catheter balloon is inserted into the iliac artery, and this catheter is inflated so that with the hope the blood supply to the uterus will be decreased or will be terminated. Now, there are a number of anesthetic implications when dealing with patients with placenta accreta spectrum. The anesthesia provider should be aware of the specific implication of surgical procedure which is being done. There should also be specific concerns in case of an unexpected, unplanned placenta accreta spectrum. Then they should be aware of the management strategies of massive blood loss and transfusion, which have to be taken care of during the intraoperative and immediate postoperative period. Cesarean hysterectomy, which is universally accepted method of in these cases, is known to be prolonged and cause significant blood loss. And if pharmacological methods fail, then intraoperatively tamponade or surgical hemostatic techniques can be initiated. There are several methods to deal with massive hemorrhage other than the pharmacological methods. These include internal iliac artery ligation. Now, if a specialist radiologist who is trained in the conventional, in the occlusion of the blood supply to the uterus is available and the instruments suitable for it are available, the resuscitative endovascular balloon occlusion of the aorta can be another option. Another option is uterine artery embolization, which again requires a skilled radiologist, interventional radiologist who is aware of the embolization techniques. Or an internal iliac artery ligation can be tried. In case we are planning for an embolization, that should be tried first, and then only you have to think about an internal iliac artery ligation. If an internal iliac artery ligation is attempted first, then uterine artery embolization may be difficult or may not be possible in the later phase. Again, manual aortic compression or clamping and pelvic packing is another method to control the intraoperative hemorrhage. That is, compression of the aorta against the vertebral body with the hope that the blood supply to the pelvis is decreased so that hemostatic as well as the hemorrhagic episodes can be decreased, and this can help in saving the patient. Now, the worst scenario is for an unplanned and unexpected placenta accreta spectrum. In this case, we have to leave the placenta in situ and perform an emergency hysterectomy. If an inadvertent removal of the placenta is tried, this could lead to a torrential bleed. And as per the ACOG Green Top guidelines, they say, if in a patient of repeat cesarean, on opening the abdomen, a placenta previa is evident, and the mother and baby are stable, then cesarean should be delayed until appropriate staff, resources, and blood products are available, so that this can help in managing the torrential blood loss. Because it has been postulated that well-planned hysterectomy carries less blood loss than an urgent hysterectomy. There are certain management strategies for blood loss and transfusion protocols. There are two important strategies as regards to resuscitation. One is the aggressive resuscitation strategy. The other is a permissive hypotensive resuscitation strategy. In aggressive resuscitative strategy is the conventional mode where large volumes of crystalloids are given during the early resuscitative period in order to restore the blood volume so that thereby normalizing the blood pressure and the hemodynamics. But it has been seen that a hypotensive permissive resuscitation, where small amounts of crystalloids will given in the early period of resuscitation, was far more important and helped in resuscitating the patient and delayed mortality than the conventional method. In conventional method, what happens is there is large amounts of crystalloids which will cause the glycocalyx to become more damaged, and thereby the escape of fluid from the intravascular into the spaces like the leading to cerebral edema and pulmonary edema. So in permissive hypotensive resuscitation, a mean arterial pressure of 55 to 65 is aimed at, so that the organ perfusion is maintained, and once the bleeding is controlled, then we can proceed with the normal resuscitations. Another aspect of this is a hemostatic resuscitation, that is early resuscitation with blood products such as packed RBCs, platelets, and FFP, so that this helps in maintaining the coagulation, so that there is not much of dilution of the coagulation factors. So this studies have shown that hypotensive resuscitation and hemostatic reanimation has helped to decrease the mortality associated with this hemorrhagic episodes. Volume replacement is with small volumes of warm non-dextrose crystalloids and or colloids. Now there has been a say for cell saver technology as far as hemorrhagic episodes are concerned. Now, what about its role in obstetric hemorrhagic episodes? Initially, it was thought that cell saver technology was not apt because much of the debris present in the amniotic fluid could be displaced and could predispose the patient to an amniotic fluid embolism. But recent studies have shown that this is a better method, so that lesser amounts of volume of blood and blood products could be transfused, and this becomes more important in patients like the Jehovah's Witness who refuse to have their blood component therapy to be taken from others. Now, prompt is a very important evidence for massive blood transfusion protocol, which was initially started for trauma patients, but has been extrapolated to obstetric patients also. It is a prospective, observational, multi-center, major trauma transfusion. Now, this is just a massive protocol transfusion, which has been taken from the FIGO guidelines 2022. This shows that there are once the massive transfusion protocol is activated, then the blood bank will send 4 rounds, each of 6 units of PRC, FFP, platelets, and 2 rounds of cryoprecipitate. Now, what is the role of tranexamic acid? This has been shown in studies that if it is used early, within the first 3 hours, it can cause a mitigation of the hemorrhagic episodes. Now, here is a FIGO recommendation for prevention of PPH. This is basically based on all the pharmacoprophylaxis, that is for vaginal delivery and CSF and LSCS, oxytocin 10 units IV or IM. If oxytocin is unavailable, or if its quality cannot be assessed, then ergometrin, misoprostol, or carpentosin can be tried. Perioperative, in between, the patient's uterine tone should be assessed to see if there is an increase in tone. FIGO has also given recommendations for treatment of PPH. And IV oxytocin is the first line neutrotonic. If oxytocin is unavailable, ergometrin or a combination of oxytocin ergometrin can be tried. However, the limiting factor for these pharmacoprophylaxis are the side effects associated with it. When ergometrin is used, patient should not be hypertensive, and their cardiac problems should not be coexist. Misoprostol 800 microgram orally. Patient's initial fluid resuscitation with isotonic crystalloids has been tried. And as mentioned earlier, tranexamic acid has been tried in the early management of hemorrhagic bleeding episode. Uterine massage continues to be an important part of prevention and treatment of PPH. Now, as mentioned earlier, non-surgical techniques like uterine balloon tamponade, uterine artery embolization, if we have the facilities and the personnel who is involved in it, then we have the non-pneumatic anti-shock garments, which are also in its way to surgical interventions like uterine or hypoplastic artery ligation can also be tried. And last but not the least, hysterectomy. Thank you.
Good evening, madam. Good evening. Thank you. There was a delay from our part. Dr. Rajesh was not able to come in. Thank you very much, madam, for the excellent talk on the management of PPH. If there are any questions, I don't find any questions in the chat box, only the comments, what is mentioned here. Any questions, you can ask, unmute and ask. Madam, you could see the chat box?
Yes.
Yeah, there is a
in OT. One question, in OT embolization, if artery is not possible. Actually, it's first embolization. If there are two options between embolization and ligation, we should go for embolization first, because literature mentions that once you do the embolization, ligation may be difficult or impossible at times. So if you have an interventional radiologist who can take care of embolization and the equipment, actually, and if the patient is stable, what literature mentions is that patient can be shifted to a radiology suite and embolization tried there. And we can even opt to do the surgery in the radiology suite, but with a word of caution that we are planning for a surgery where there is going to be a lot of hemorrhage and hemodynamic instability. So it is actually a non-operating room technique. So we have to be very careful if we are planning to do it in a radiological suite. But literature mentions that we can do it provided we have the facilities.
If you have a hybrid OT,
yes,
you make it's the better good option. Otherwise, you should have a radiologically suite adjacent to the OT, so that you can rapidly shift the patient. Sorry, madam, I could not unmute it. That was the technical problem I faced. Okay, right.
And next question, madam, what is your opinion on Carpentosin compared to Oxytocin? See, the problem with Carpentosin is that when you give it in doses, even the side effects are the limiting factors as far as Carpentosin, misoprostol is concerned. That is the limiting factor. Otherwise, if you give it in combinations, they are better hemostatic agents than single. That is what it is mentioned. Yes, Paul, you have any suggestions on that?
Any participants, you can unmute who has done some work. Dr. Shamshad is traveling. She's connection is unstable. Dr. Ginny, you want to make some comments?
Would this
discussion towards practical aspects at the end of the theoretical period will be more beneficial.
That's a general comment. Dr. Ginny, you can unmute and ask directly. She has asked what's your opinion on Carpentosin use as compared to Oxytocin, because Carpentosin is now coming in a big way and pharmaceutical agents are pushing it. It's a new agent, relatively new agent. Any comments, madam?
When I looked at actually figured recommendations, 2022 says that Carpentosin can be used in combination with Oxytocin. However, its side effects like diarrhea, abdominal pain are the limiting factors. But otherwise, they are good options as far as their hemostatic effects are concerned.
Okay, madam, actually some of the obstetricians right now, they are insisting on the use of Carpentosin. So maybe they have attended some seminars or something. So they say Carpentosin, you have to use Carpentosin, please don't use Pitocin. So I was wondering like if there is anything specific other than what we know. That's it.
Srijit Mohan has asked mefentramin or noradrenaline infusion better.
I think in this setting, a noradrenaline infusion would be a better choice because this is a massive hemorrhage. When you talk about massive hemorrhage, you have to see it to know what is the consequences. At times, even all the pharmacological, as we said, all the pharmacological agents, even in combinations, even if you try them, you find it difficult to control the bleeding and attain hemodynamic stability. So I think in that situation, noradrenaline infusion would be a better choice. Any comments from the audience?
Yeah, definitely. You have to activate the MTP, massive transfusion protocol, depending on the situations. And once you have increased the dose of noradrenaline, you can add additional agent also like vasopressin. Or even you can, if depending on the amount of hemorrhage, you can consider conversion to GA if it is not, and putting a central line and artery line at this point.
So it's a very practically very difficult. It is easily said than done.
Yeah,
it can be easily said, but when it comes to practical situations, things are a little difficult because you have a young, healthy patient who is bleeding profusely, and at times you find it that none of your techniques are able to keep back that your resuscitation methods to the perfect. So it becomes very difficult at times.
Also, madam,
Shah, would you like to speak? Yeah, Ginny, continue.
Yeah, madam, actually, what is your opinion on the indiscriminate use of tranexamic acid? Actually, most of the obstetricians, they go on a routine use. They insist on first giving Pitocin, Oxytocin. Then they say, please give methogen. Then they say, please give tranexamic acid. That's actually for all the patients. Indiscriminately, they use it as a prophylactic use, actually, just to because they are fearful that the patient may land up in peak pH. So what's your opinion about it? Or should we insist on, should we say that it's not possible? We'll just wait and see and then give.
Actually, what they say is tranexamic acid is a good option if you give it as early as within the first 3 hours. So actually in FIGO transfusion guidelines, if you had seen that slide, in the 3rd round, they have added tranexamic acid, 1 gram. And they said that you can repeat it if the bleeding still continues within the 24-hour period. So that I don't think it's harmful anywhere in any way, but how far it is useful, I think the studies need to be done more on that. Yes, anything, Rajesh?
So, Dr. Ginny, hello? So CRASH 2 trials has shown the usefulness of tranexamic acid in trauma situations. And in obstetric patients, I don't know, I'm not sure. But as Madam said, it has to be given at early, take some time to act.
Intramural prostodine. Somebody has asked, which is better or safe? Intramural prostodine or IM? Which is better and safe?
Prostodins are known to cause smooth muscle contraction and constriction. So they can cause, whether it is intramural or IM, it can cause bronchoconstriction. They can, so their side effects remains the same, whatever be their route. So I'm not able to say which is better, because I have seen a patient who was given intramural prostodine, and patient developed severe bronchospasm, which we found it difficult to treat. Rajesh, any comments on that?
About intramural prostadine.
Intramural IM.
I don't know. Okay. Intramural bar IM. Okay. So not sure about intramural, but we used to give a IM prostadine.
No, we had obstetricians who used to give intramural, and we had one patient who developed a severe bronchospasm. So.
Okay. So, Dr. Ginny, you can unmute and give your comments. She's saying that prostadine has not been included in the international guidelines. I think our connection is very unstable. Any comments from the faculties? Or any question? Vibhul Shah, you can unmute and ask directly. Dr. Paul, Dr. Vibhul Shah, Shah Vibhul, please unmute him.
Hello.
Yes, you can hear.
Yes. Regarding tranexamic acid, I have a very good experience. Yeah, apart from the PPH, generalized oozing in case of the previous surgeries, it gives a very good result. Hello.
Yes, can you please continue?
Yeah. So I'm since last 5 years, I'm practicing to give 2 ampules of tranexamic acid half an hour before the induction of the planned CS, in which case there is a previous CS. And I have experienced a very less amount of the oozing. So many times scars are bad or something like that. Even in orthopedic surgeries, I have find out this very effective. So I would like to suggest it is to be given in almost all cases. There is no contraindication or no harm in giving the tranexamic acid. So if we get a bleeding and then we give, then it takes at least half an hour to work. That is number 1. And that is number 2 regarding Carpentosin. I have a series of 25 patients. Only advantage is that if Carpentosin works, then you don't have to give methargine. So complication of methargine on table, that is the vomiting and the headache. So that can be prevented. But in out of 25 cases, in 6 cases, I have to give methargine because the uterus contractility was not that much and there was a bleeding. So I have to give the methargine addition. So at least it is almost 20% cases we have to repeat. So apart from the cost, there is no more advantage if we see the repetition of 20%. So that is regarding Carpentosin. Okay. Any other practitioner has some experience regarding that, more than 25 cases of series? Please guide.
Okay, thank you, Dr. Vipul. I think tranexamic acid is relatively safe.
Yeah.
Drug, especially unless the patient has got a thrombotic tendency or a coronary event, recent coronary event.
Okay.
Dr. Suvarna, you can unmute and give your comments. She has. Dr. Suvarna?
Hello.
Yeah.
Hello.
Yes,
Hello.
so-
We also use tranexamic acid routinely in all major surgeries, especially spine surgeries and in even in obstetric surgery. We expected massive hemorrhage like placenta previa, Acryla. In all those cases, it should be given as early as possible, as Madam said. So there is no harm in giving tranexamic acid. We used to give 1 gram.
1 gram stat and 1 gram in the next 8 hours. That's the standard regime, no? Hello?
Dr. Suvarna?
I think except in GI surgeries, in most other situations, as she has mentioned in spine surgeries and replacement, knee replacement, hip replacement surgeries, and all, most of the situations we gave it routinely. I think our connection is.
No, she is.
Hello.
Yeah.
You're back.
Suvarna.
Hello. Yes, we used to give in for all major surgeries, like all hip replacement, knee replacement, all orthopedic major surgeries, and in obstetrics also expected to have all surgeries expected to have major bleeding.
You were discussing about the repetition, like
We used to give 1 gram bolus and then after that 1 gram infusion.
Infusion.
Yes.
Shah Vipul has asked any literature regarding coronary events.
It's a very controversial thing. The thing is that it's a theoretically it can cause. You are giving it for clotting the blood, and theoretically it can cause. It can be harmful in acute coronary events. That's what I mentioned. But
regarding vitamin K, any role of vitamin K?
Vitamin K is as long as your liver is working. I don't think. Yeah, liver transplant it is given. That's Dr. Kusuma Ilemani is That's it's an entirely different set of scenario. That's why I didn't mention this. But the hepatectomy is we don't give it routinely because unless towards the end of the surgery, when the surgeon insists that there is still oozing or coagulation defect, we go by the TEG and correct the component rather than giving tranexamic acid in hepatectomies and all major hepatic dissections. And the liver transplant, we give it routinely. We have a regime. And thromboelastogram can be utilized if facility available in major obstetric hemorrhages also. Madam has mentioned about it. There is no worries. Thank you, madam. And we'll go to the next session. Is the postgraduates ready?
Hello, next we'll go for the PG session. We have two topics here. One is about the video laryngoscope and other is about adrenaline and noradrenaline. We have the postgraduates from Amala Medical College. To moderate the session, we have the head of the department, Dr. Lini Chako, with us. Over to Dr. Lini Chako.
Hello, am I audible?
Yes, audible and visible.
Good evening to all. First of all, I would like to thank ISA organizing team as well as academic team for giving us an opportunity to present the topics. Today, I have with me 2 second-year postgraduates. First is Dr. Shinu will be presenting on the topic noradrenaline and adrenaline, and Dr. Shilma on the topic video laryngoscope. So, over to Dr. Shilma for the presentation on video laryngoscope. Thank you, ma'am.
Good evening, sir. Today I will be presenting on the topic video laryngoscope. First, let's start with the history of video laryngoscope. As you all know, the principle of indirect air visualization on which video laryngoscopy is based is actually older than direct laryngoscopy. In 1829, Benjamin
Shilma, sorry for the interruption. If one more the device is opened there, please mute the device. There is echo. It's echoing. If you have opened 2 devices.
Okay, sir.
Okay.
Hello, is it clear now?
Yeah. Okay. Continue.
In 1829, Benjamin Badminton described glottoscope or glottoscope, in which he used a speculum to displace the tongue and a system of mirrors to visualize the larynx with sunlight for illumination. Then in 1895, Alfred Percy described an otoscope which had an external source for visualization. In 1940s, McIntosh and Miller blade were introduced, and the direct laryngoscopy has been the gold standard for endotracheal intubation. Then in 1958, John P. Huffman described Huffman Prism. This is the diagram of Huffman Prism. It is a specially shaped acrylic with one end flat and another end having a 30-degree angulation, and it also have a metallic clip. What they did was they clipped this prism into the flange of the McIntosh blade, and this helped in situations where direct visualization was difficult. But problem was that it was very quite bulky, so the manipulation of endotracheal tube was difficult. Then later, in 1998, Marcus Weiss incorporated fiber optic fibers into a direct laryngoscope with a McIntosh blade. Then the first video laryngoscope, that is the Glidescope, introduced in 2001 by John Pacey. Then coming to role in airway management, the Difficult Airway Society in the 2015 algorithm recognized the use of video laryngoscope as part of the airway management and suggested to all anesthesiologists the adoption of video laryngoscope skills. It is recommended that video laryngoscope should be immediately available for all obstetric general anesthetics. And in 2017, DAS presented video laryngoscope as an equivalent technique to direct laryngoscopy in the first attempt of intubation in the airway management algorithms in ICUs. Let's look how a video laryngoscope works. Video laryngoscope provide an indirect view by having a camera lens close to the tip of the blade nearer to the larynx. This results in a much wider angle of view compared to direct laryngoscopy. And the light source and camera are powered either from the monitor, like in Glidescope, or by an internal battery, like in Kingvision. And the light projected from the video laryngoscope blade and the wide field of view of the camera result in a more panoramic view of the larynx compared to direct laryngoscopy. The lenses used by different video laryngoscopes are not identical and have different field of view and varying level of distortion. For example, Magma has got a narrow field of vision compared to Glidescope. And the majority of video laryngoscope uses a light emitting diode, light source, and a complementary metal oxide semiconductor, that is CMOS sensor. The CMOS sensor converts the light signals to electrical signals at high speed with low power consumption. And the images generated from the CMOS chip are then sent to the video screen of the video laryngoscope. Actually, the video laryngoscope works on the principle of looking around the corner, which is made possible by keeping the lens close to the tip of the blade. In this diagram, you can see first is the direct laryngoscopy with McIntosh blade, second is the indirect with McIntosh blade, and third is the indirect with highly curved blade. As the curvature of the blade is increasing, the angle of refraction is increasing, and it will provide a better view. For a problem with hyperangulated blade are the endotracheal tube trajectory will be very difficult. Coming to classification, according to the method of tube advancement, we have channeled and non-channeled. Channeled include AirTrack, Pandax Airway Scope, and King Vision, and non-channeled include Glidescope, Magma and CMAC. According to the curvature of the blade, we have standard Macintosh blade like in VMAC and CMAC, and angulator blade like in Magma, Glidescope, and CMAC with T blade. What are the important indications of video laryngoscope? In airway pathology, difficult airway like in trauma, tumor, and previous surgeries, and in immobilization of cervical spine, education, teaching, and purpose of documentation. Sometimes it happens that is, despite good glottic view, we are not able to pass the endotracheal tube. What might be the reason for that? First, endotracheal tube is first scenario, that is endotracheal tube is not going towards the glottic opening. It is rather going downwards. Either we have kept our endotracheal tube so straight. So try to make a C shape or pokey stick with a stillet and also apply sufficient lubricant. In another scenario, the endotracheal tube is at the glottis, but we are not able to negotiate the tube towards the glottic opening. It might be due to that the stillet along with endotracheal tube is hitting against the anterior tracheal wall. So for that, we have to remove the stillet before advancing endotracheal tube. As we push the tube in, we have to pull the stillet up. Sometimes it happens that is even after the removing the stillet, the endotracheal tube may hit against the anterior tracheal wall, and we are not able to pass on. For that, we have to rotate the endotracheal tube over the stillet, and application of lubricant at the tip of the tube will also help. Another mistake everyone will make is placing the end of the scope too close to the glottis. As you can see in this diagram, if you are keeping the end too close to the glottis, the field will be very narrow. So don't keep the end of the scope too close to the glottis. Let's discuss about some commonly used video laryngoscope. First is the AirTrack. AirTrack was developed and patented by Dr. Pedro Acha. And there are two versions, AirTrack SP and AirTrack Avant. AirTrack SP is an entirely single-use device which is available in both pediatric and adult versions. It's channeled blade. These are color coded. And AirTrack Avant, which contain a disposable blade and reusable optic. This reusable optic is charged in docking station in between uses and discarded after 50 uses. Both these versions can be video enabled in two ways. That is AirTrack Mobile, which is a smartphone app which can be connected with phone adapter, and we will get the videos and images in our smartphone. And there is another way, that is via the Wi-Fi camera, wireless transfer of the images to smartphone and laptops. And AirTrack has got an anti-fogging mechanism which is enabled by turning on the scope 60 to 120 seconds prior to the use. Once it is turned on, there is a heating element at the tip of the scope which heats the lens until the desired temperature has been attained. And there is an LED indicator for that also. Both adult and pediatric sizes and a size to accommodate double lumen tubes are available. Next, about Pandax Airway Scope. It contains a proximal handle with a 2.4-inch video display and batteries, ending distally in a cable that houses an LED light and a CMOS sensor. The cable drops down to a single P blade, which is a polycarbonate blade available in different sizes. And this blade has a separate channel for suction catheter and endotracheal tube. A unique feature of this Pandax is that there is an AMI reticle or crosshairs, as you can see in this diagram, which helps us to guide the tube towards the glottic opening. The first generation was AWS S100. It has been upgraded to AWS S200, which is more lighter weight and it is water resistant. Next, about the King Vision. It's a fully portable and wireless video laryngoscope. It's a battery operated display with a 2.4-inch organic LED screen. It works with a AAA batteries with a life of 90-minute usage. And a more recent variation, that is King Vision A blade with a video adapter that include an LED light and CMOS camera in its distal tip is available. Only one blade size is provided for adult use, tube size of 6 to 8 millimeter. Clear single-use anti-fog-coated air blades are also available. This shows the different sizes available. That is, AirTrack SP is available in regular, small, pediatric, infant, and for nasotracheal and double lumen tube. AirTrack Avant available in regular and small size. Kingvision only one size. Pandax is also available in adult and pediatric size. Next, about Venner AP Advanced Video Laryngoscope. It contains a video viewer with a 3.5-inch screen, which is a little bit bigger, and it single-use blade option. We can use Macintosh 3 and 4 blade and difficult airway blade, and non-channeled blades can also be used. And the camera module incorporates a high-intensity LED light source and a CMOS camera sensor. It's a battery-operated device and rechargeable. Single-use blade are anti-fog coated. Next, about the Glidescope. As we already said, it was introduced by the Canadian surgeon John A. Pesci in 2001. And since its introduction, there has been numerous changes for both laryngoscope blade and the screen. There are single-use plastic and reusable formats are available. Both Macintosh and angulator configurations can be used. And the new blade configurations are referred to as titanium, even if it is a single-use or reusable format. It is very lightweight with slim design. And Glidescope series previously was referred to as Cobalt, and it is now called as AVL single-use system. It has got an anti-fogging technology made by turning on the machine 30 to 120 seconds prior to the use. There is a variety Glidescope Ranger. It has got same blade configuration as that of the AVL single-use system, but the monitor is very portable and compact, and it is used for emergency medical services and for military purposes. Next, about the CMAC. It was introduced in 2003 by Kaplan and Bercy, and it is based on a modified Macintosh blade. That is, the curvature of the blade is similar as that of the 9043 version, but it is more thinner, maximum of 14 millimeter and beveled shoulder. So this thinner blade permit the use even in patient with a limited mouth opening, and the oral and dental injuries is also less. It's compatible with various blades. There is a C-cam, that is clip-on camera, by which we can attach it to rigid and flexible fiber optics. There is a 7-inch LCD monitor with push buttons. A push button helps to record the system. Another variety is the CMAC PM, CMAC pocket monitor, which has got a 2.4-inch LCD screen, and it is lithium battery operated. D-blade may be attached to the system within seconds if needed. Next, about the McGrath video laryngoscope. The McGrath Series 5 was developed by an industrial designer, Matt McGrath. This is the structure of the McGrath Series 5. It has got a camera stick, which is a stainless steel, which we can retract or advance to 3 different lengths. And it has got a handle, which is made up of high-grade rubber. And there is a monitor, which can be swiveled to optimal angle. This McGrath Series 5 has now been superseded by McGrath Mac Enhanced Direct Laryngoscope. This is the Mac Enhanced Direct Laryngoscope. The difference is that this camera stick is in a fixed position in this EDL version. It's a portable and relatively inexpensive capital and disposable coasters, but it lacks the recording capability and is susceptible to some degree of fogging. Next is a split type Osmond video laryngoscope. It's a recently introduced video laryngoscope. It contains a reusable core, disposable blade, and monitor. Because of the presence of 92-degree channeled blade, still it is not required for intubation. And the core is completely enclosed by the blades, avoiding the necessity of sterilization after each use. And the monitor can also be rotated and tilted as per our convenience. Next, let's look into advantages of the video laryngoscope. It provides an improved laryngeal view, and alignment of oral, pharyngeal, and laryngeal axis are not required in this case. And there is only less movement of cervical spine. It's a primary choice in pre-hospital settings. It provides high resolution images and only less distortion of images with the secretions blood as compared with fibroscopes. Teaching direct laryngoscopy at airway anatomy is very easy with this video laryngoscopes. Video image guided endotracheal tube exchange can be done. What are the limitations of video laryngoscopes? First and most, adequate mouth opening is required, And intubation may prove to be difficult despite good laryngeal view, as we already discussed. And injury is possible during the tube advancement at blind spot. And additional cost and maintenance is needed. Different skills, hand-eye coordination is required. Clear role in airway trauma or pharyngeal tumors is not established as yet. And fogging and secretions are a common problem in video laryngoscope. But there are anti-fog heating mechanisms built into camera like in stores and glidescope. And there are anti-fog coating on disposable blade in like McGrath or lens in Kingvision. And adding oxygen may help in anti-fogging, and successive early aspiration of secretions is also effective. Kepler intubation system was the first human robotic intubation system in which they used the Pandax airway scope. And this system is named in honor of astronomer Johannes Kepler, best known for his laws of planetary motion. The success rate was 91%, but future studies is required for further human safety and performance. As we all know, it is COVID-19 era. In this COVID-19 situation, All India Difficult Airway Association guidelines state that video laryngoscope assisted tracheal intubation is recommended, as it avoids the close proximity with the patient. The infection rate is also reduced. There is a LARA trial. It was one of the largest multi-center trial conducted in 1,000 patients, and they compared the McGrath video laryngoscope with that of the standard with the direct laryngoscope in patients undergoing rapid sequence induction and intubation, and found that the first pass intubation rate was more with the video laryngoscope, and also the airway related complication like hypoxemia and aspiration was much reduced while using McGrath scope. Then another trial is a Magma Trial. That is, it was the first trial of first randomized trial of video laryngoscope in ICU patients. And again, they compared video laryngoscope with direct laryngoscope in critically ill patients. Here also, the first pass intubation rate was more with video laryngoscope. So there was another trial, which is the IMA trial. This was the trial conducted in, again, a multi-center trial conducted in 2,000 patients, and they compared the McGrath laryngoscope with standard direct laryngoscope in first pass intubation, and the first pass intubation rate was more with the direct video laryngoscope. Then what about intubation trauma? Video laryngoscope requires only less force, around 5 to 10 Newton to the base of the tongue, while direct laryngoscopy requires around 35 to 50 Newton. So the force and pressure required with video laryngoscope is very less, and so the soft tissue injuries is also decreased while using video laryngoscopes. Role of video laryngoscope in pediatrics. Most of the video laryngoscopes are also useful in older children, but only few video laryngoscopes are available in sizes for children less than 2 years. Pediatric versions are AirTrack, Glidescope, CMAC, TrueView PCD, Infant, and McGrath. And this was one of the study in which they compared the efficacy of Glidescope with the direct Glidescope versus the direct laryngoscope in children who are difficult to intubate. They conducted the study among 1,295 children and found that the Glidescope was better, superior when compared to direct laryngoscopy. Thank you.
Thank you, Shilma, for the presentation.
You can call upon the next postgraduate.
Dr. Shinu.
Yes, madam.
You can present.
Good evening, all. Good evening all. I am Dr. Shiniman from Amma Medical College. Today my topic for discussion is adrenaline and noradrenaline. As all of you know, adrenaline and noradrenaline are naturally occurring catecholamines produced from the adrenal medulla. They have stimulatory effects on sympathetic system and hence classified as sympathomimetic drugs. Synthesis of catecholamines. All catecholamines are monoamines derived from phenylalanine and tyrosine. There is a series of metabolic reactions involved in the synthesis, which is the first step is oxidation of tyrosine to levodopa, and next is a decarboxylation of L-dopa to dopamine, and the oxidation of the dopamine to noradrenaline, and finally the methylation of noradrenaline to adrenaline. And the steps are depicted in the following picture. Let us discuss a few words about adrenaline. It is a drug which acts mainly to increase the cardiac output. Epinephrine typically released during acute stress and prepare an individual for flight or fight responses. Small amount of adrenaline released from the sympathetic nerve endings. It was first identified by American physiological chemists John Jacob and Jokichi Takami in 1900s. It was first synthesized by German chemists in 1904. The structure of adrenaline composed of a catechol unit, which is a benzene ring with 2 hydroxyl group, along the side a methyl group which is affixed to nitrogen molecule. Preparations, it's available as epinephrine bitartrate. It's a clear solution with a 1 ampule of adrenaline contains 1 ml in a concentration of 1 in 1000 solution. It is associated with the local anesthetic solutions in 1 in 2 lakhs concentration at maybe as high as 1 in 80,000 ml with a lignocaine 2% for dental injections. And adrenaline is used in anaphylaxis as auto injectors like EpiPen with a concentration of 0.3 mg and 0.15 mg for intramuscular injections. And adrenaline is another preparation is adrenaline racemic mixture which contains dextro and levo isomers of adrenaline. Levoadrenaline is the active form, hence the racemic adrenaline mixture is less active and fewer cardiovascular side effects when nebulized. To use adrenaline safely, it is important to understand the concentration and total dose of the adrenaline you are using. So 1 ml of 1 in 1000 solution contains 1 milligram, and 1 ml of 1 in 10,000 solution contains 0.1 milligram, and 1 ml of 1 lakh contains 0.01 milligram, and 1 ml of 2 lakhs ml contains 5 microgram. Mechanism: it acts non-selectively on all adrenergic receptors to produce flight or fight responses. As we know, the adrenergic receptors are G-protein coupled receptors. Its mechanism of action is via membrane receptors, which trigger a second messenger response. Pharmacodynamics: it acts on various organs in the body. Through alpha-1 receptor, it produces vascular smooth muscle contraction, and alpha-2 receptors present on the CNS into presynaptic nerve endings. It causes sedation, analgesia, and activation of sympathetic responses. Through beta-1 receptors, it produces beta platelet aggregation, and in the heart, it produces positive inotropic and chronotropic effects. Beta-2 receptor stimulation produces relaxation of the bronchi, smooth muscles, and uterus, and through beta-3 stimulation, it produces lipolysis in adipose tissues. With the pharmacokinetics, it has a half-life of 2 minutes, and it is not given orally as it is inactivated by the oral absorption. And when given subcutaneously, it is less rapid absorption than intramuscular. Adrenaline is broken down by monoamine oxidases and COMT, which is catechol octaminyl transferase, and it is excreted by the kidneys. Clinical application: it is the drug of choice for the treatment of cardiac arrest. And its main action is to increase vascular resistance by alpha-1 receptors and produce vasoconstrictions and improves the perfusion pressure to myocardium and brain. When treating a shock couple becomes like a ventricular fibrillation and pulseless VT, 1 milligram is given after second shock and then every 3 to 5 minutes. For pulseless electrical activity, 1 milligram is given as soon as the intravenous access is achieved, and it is repeated in 3 to 5 minutes. Greatest effect when given intravenously, but it may be given by intraosseous routes. It is tracheal administration of this drug is not recommended due to variable absorption and poor efficacy. Then in neonatal resuscitation, if the heart rate is less than 60 beats per minute and 45 to 60 seconds after the initiation of positive pressure ventilation and chest compression, an infusion dose, we can use a 0.01 to 0.03 milligram per kg of 1 in 10,000 solution followed by 1 ml saline flush. If venous access is not obtained, epinephrine can be given through endotracheal tube with a dose of 0.05 to 0.1 milligram per kg of 1 in 10,000 solution. It can be repeated in every 5 minutes. And it's the drug of choice for another condition is anaphylaxis. Through its alpha-1 agonist action, it reverses the peripheral vasodilatation by inflammatory mediators release and reduces edema. Through beta receptor activity, it dilates bronchial airways, increases myocardial contractility, and suppresses histamine and leukotriene releases and attenuates the severity of IgE-mediated allergic reactions. Okay. In anaphylaxis, the preferred route is intramuscular, and it is the best site is anterolateral aspect of the middle third of the thigh. Because of the fewer adverse effect, it is the most preferred route for anaphylaxis. It is repeated at 5 minutes interval and if no normal according to the patient response. Then we will discuss some doses of adrenaline in the management of acute anaphylaxis. So intramuscular dose we discussed in 1 in 1,000 solution, and the intravenous dose is in 1 in 10,000 solution. For adult and children more than 12 years, 500 micrograms intramuscular dose is given, and IV dose of 50 micrograms is given for both the groups. Children with 6 to 12 years, we give 300 micrograms of intramuscular dose and 1 microgram per kg titrated to the effect in intravenous dose. For children less than 6 years, we give 150 micrograms and intravenous dose of 1 microgram per kg titrated to the effect. This adrenaline is always given as a continuous infusion in the intensive care environment via central venous catheter with an invasive blood pressure monitoring. It's an inotropic for inotropic support. The indications of adrenaline is profoundly low blood pressure, shock, and low cardiac output states. The target dose is usually given as microgram per minute or microgram per kg per minute. The rate of infusion is titrated to effect usually to achieve the predetermined target blood pressure. For shock in children, the dose is 0.05 to 2 microgram per kg per minute. In adult, the dose is 0.01 to 0.5 microgram per kg per minute. Maximum rate of infusion is 100 microgram per minute. For airway obstruction, for severe group, most common airway indication for adrenaline, and racemic adrenaline is usually nebulized in these conditions. Its mechanism is it reduces local inflammatory process and it produces vasoconstriction, thereby reducing the obstruction caused by the edema. For children, the racemic mixture is 0.5 ml. Children 0.5 ml kg of 1 in 1,000 solution, maximum 5 ml of levoadrenaline is given as a nebulizer. For racemic adrenaline, the dose is 0.05 ml per kg, maximum 1.5 ml of 1% solution is given. For smaller for conditions other than flu, smaller doses are given. All the anticipated side effects of systemic adrenaline may occur, so the patient is monitored at high care environment. It can also be given as a topical dose. Produce a local vasoconstricting action, and the addition of adrenaline to a local is produced at prolonged action by decreasing the prolonged action and reduces bleeding for operations at the site of injections, and it's supplied topically by the surgeon to reduce bleeding. It should be administered with caution because of its profound effect on cardiovascular system, and should be extra care in patients with arrhythmias, hypertension, ischemic heart disease, as these conditions may be acutely exacerbated, and caution patients taking monoaminoxidase inhibitor. And side effects include palpitation, tremor, lightheadedness, tachycardia, arrhythmia, hypertension, cerebral hemorrhage, and acute pulmonary edema. Biochemical, it produces lactic acidosis. And the next is noradrenaline. It's a catecholamine with multiple roles, including hormone and neurotransmitter. It acts as a stress hormone along with adrenaline. It underlies a fight or flight responses. Norepinephrine also suppresses the neuroinflammation when released in the brain from the locus ceruleus. As a drug, it increases blood pressure by increasing the vascular tone on alpha activation. It increases the vascular resistance, triggers a compensatory reflex that over the direct stimulatory effect to baroreceptor reflex, and there is a drop in the heart rate, which is the reflex bradycardia is produced. It is first identified by Swedish physiologist Ulf von Euler. And it is structured similar to adrenaline. The difference is that the methyl group in noradrenaline, methyl group is replaced by hydrogen atom. Preparations, noradrenaline is available as a noradrenaline bitartrate. 1 ampule contains 2 ml, which contains 2 ml of noradrenaline bitartrate active component, equivalent to 1 milligram per 1 ml of noradrenaline. It is potent vasoconstrictor and has more alpha action compared to beta. It predominantly causes peripheral vasoconstriction and increases blood pressure. It has slight anotropic and chronotropic action. It has no or minimal beta-2 activity. It takes 1 to 2 minutes for its onset of action, and duration of action is 5 to 10 minutes, and it has half-life of 2 minutes. Majority of the mechanism of drug elimination by the active reuptake from the nerve endings, and the pharmacokinetics is similar to adrenaline, which is metabolized by COMT and MAO. Clinical use, it increases the blood pressure in acute severe hypotensive states, and the dose is 0.05 microgram to 0.5 microgram per kg per minute. Noradrenaline is the vasopressor of choice for managing septic shock. An extreme caution should be taken with the patients having high blood pressure and in pregnancy and patients with peripheral or mesenteric vascular thrombosis, as the inflammation or injury small intestine results from inadequate blood supply. Side effects, it produces reflex bradycardia, arrhythmia, myocardial, mesenteric, renal, and peripheral ischemia, and hypertension. Thank you.
Dr. Lini.
Thank you, Shinu, for the presentation. And any opinions and any suggestions regarding topics? Any questions?
There are no questions in the chat box. Regarding the first topic, video laryngoscope is a real blessing in this era. And as rightly mentioned, one of the things we have to take care is, like, if you go to the root of the epiglottis and lift, it will not be possible to view the glottis. So that's a learning curve what we have to practice. Those who are practicing on video laryngoscope, it's not the direct laryngoscopy. How you do the direct laryngoscopy, it's not like that. You need not go to the vallicula and lift it. You have to be little far away from, means like you should not reach to that area. Now video laryngoscope, the rechargeable ones have come. Earlier it was not that like we had to we had to dispose it like after few uses. So now rechargeable ones with the bigger screens have come. Earlier one, it was the fogging was an issue, and now anti-fog blades have also come. And what's your experience with the channel and non-channel?
So we are having channel blade Kingvision, and I find that Even though the view is better, sometimes we feel difficulty in intubating. So we have to use, sometimes we have to use bougie and all to get the tube directly.
Regarding the channel, you are saying it's difficult.
Maybe in some cases.
Yes, true.
Even though we get a wide view and the closer and highly resolution view, the intubation at times may be difficult. So as you said, the learning curve is it is described short, but we have to have sufficient experiences with the normal airway before attempting to do it in a difficult airway or for a critical patient in SU. We have to do practices and we have to do sufficient attempts in the normal patients, and then only we have to do for a difficult airway. Otherwise, it may not help actually.
Okay, thank you. Any of the senior faculties who are here or anyone would like to comment, please do unmute and comment. Or any postgraduates, need not be the senior person. In your experience, you can always comment.
Actually, video laryngoscope is a great blessing to our practice, but what we need is cheaper options, which can be bought by maybe freelancing, and the usual what we have in our institutions is very costly. So
which
what
one
are
you
the
are
cheap?
using?
CMAC.
CMAC, that's the most expensive one you are using.
So maybe like we are planning to buy this Tascope, which is about 6,000 rupees per piece, I believe. So what are the other options, other cheaper options that may be bought individually? Like for the other options, what are the cheaper options?
The one you are saying, it has a camera, you'll have to look into like the air track.
Yeah, there is a Tascope actually, which can be connected to our own mobile.
Okay.
The Airway Society, some fraternity belonging to the Airway Society made it. It's freely available. Actually, the cost is only around 6,000 rupees. So are there any other possibilities other than the Tascope, which is cheaper?
I don't think anything lesser than 6,000 is available.
Actually, the Tascope, the handle is a bit flimsy. So I don't think it is recommended for multiple users. If I buy it myself, then maybe if I take care of it properly, then I'll be able to use it. But otherwise, it's not that sturdy. It's a bit flimsy. It's plastic. So anything else which others know, if they can share?
You can unmute and answer or give comments. The latest one, the cameras are not fixed, so it will be easier. Otherwise, the one like Magma Trial, where it is fixed. Now they have come out with the civil type also. It is fixed. It will be difficult to negotiate.
Magma 5, I think, adjustable camera.
Adjustable one.
Okay.
Somebody would like to comment? Please comment. Yeah, Ginny, you are saying something?
Also, one advantage is, I think, the assistant can also see the good view, so that he also can help the operator by optimal manipulation if needed. Unlike the direct laryngoscopy, where they are giving blindly the assistants for external engine manipulation, they are giving blindly. In this case, we can the assistant can see the glottic view like the operator, and he can help him
assist
more optimally, I think.
One of the actually the side means like disadvantage what was mentioned by Dr. Shilma was regarding the injury. What is the percentage of injury you get? Injury to the structures before we see in the camera. You had mentioned, no, Dr. Shilma?
I think this is a rare complication. So injury may be less.
Very rare, I think.
Rare.
We are not- Maybe we may get that in an inexperienced hand. Regarding adrenaline nebulization, they have asked for. Somebody has asked.
Levoadrenaline, the says that it's our adrenaline only. We are using it for medical uses. It's actually levoadrenaline.
For nasal packing ENT, FES, usually 4% xylocaine with adrenaline is used. How many adrenaline ampules can be used safely per vial of xylocaine?
Why is that question? See, it is that you have to see whether you want one in 200,000, one in 80,000. Accordingly, you calculate how much you use.
Yes.
It is a simple question. We have to calculate that. That question should not be asked to a speaker. What concentration you have to ask and do that. What concentration you have to ask.
It's always better 1 in 2
when
lakhs.
you want
You
1
will
in
have to use.
200,000, you have to, how much you use, that much you have to add.
Also, we should avoid this lignocaine with adrenaline when we are blocking digital blocks, etc. You should avoid as they are end arteries. And another point is that this lignocaine with adrenaline can sensitize the heart to arrhythmias when they are using the inhalation anesthetics like halothane.
Well, regarding video laryngoscopy, it should not be used only in the difficult airway. We have to start using it in regular laryngoscopy. Otherwise, see, when it is difficult, you will not be. It is a learning curve is there.
Yes,
so
sure.
We should start using it regularly, unless because now we are accustomed to regular. We feel very easy. See, using a regular. Unless we use it regularly for our routine cases, in a difficult, it is very difficult to use because I also has got that. Video laryngo. Unless I use it regularly for the cases, in a difficult time, I will not know how to use that, and it is very difficult. Coordination will not come there, hand and eye coordination. So we have to promote to use it regular cases. Then only we can use it in a difficult airway, not just directly using in a difficult airway. It's very difficult. Then our regular laryngoscopy becomes easier than a video laryngoscopy.
Yes, true, sir.
Actually, sir, the regular use of video laryngoscope has made it faulty. Actually, in our institution, whatever we were using, all of us were quite used to using it for every difficult airway. That we are finding it very difficult right now because we don't have it. So that's why we were just searching for other alternatives, which are cheaper alternatives, because like each of us cannot go and buy it.
You know, all actually all the intubation should be supervised. If a novice is starting is doing it, so later it may like after the learning curve or when you get used to it, it will be may not become faulty. You said faulty because of the
some cable, something is wrong. So they have sent it to Delhi and
CMAC,
CMAC. Okay. So we may have to wait for another 1 month. So actually, it's all we have is just one CMAC in our theater. So it's difficult.
And what is your experience about that? The D blade, you have the D blade with you? D blade of CMAC, which is used in.
No.
Recently, a company has come, but it is almost nearly 2 lakhs with all these 5 blades.
Okay.
But the screen is much bigger, 2.5. There is a provision for recording. There is a provision for still picture also.
Okay.
Anyone would like to speak?
Hello.
Yeah, please.
Yes, sir. Dr. Nilesh Shah here from Baroda. Sir, before COVID, before this COVID, first of all, sir, all the 3 lectures were excellent, and it was a wonderful academic meet. And sir, hello.
Yeah.
Can you listen me, sir?
To you. Thank you
Yes, sir.
for attending.
Yes,
You
sir.
can
Thank you,
continue.
sir. Sir, I use King Vision video laryngoscope regularly before COVID area. But just madam was asking about the most cheapest alternative.
Okay.
So since last few months, I am using mainly the ramp position. So what we are doing, we are putting 3 pillows during intubation. Hello.
Yeah. Listening.
Sir. So RAM position is the excellent this thing during the intubation, and I think we are not mentioning about this routinely. But in this COVID era, there are lots of problem of the sterilization of the blade of this video laryngoscope and all. So gradually we have reduced use of this video laryngoscope to avoid all these issues. And sir, we are very happy with the this thing. So just what I want to mention, key in each OT or ICU, at least we should have 3 pillows, and that we should give the ramp position. So that helps in intubation very much.
You're saying the ramp position for video laryngoscopy or for the direct laryngoscopy?
No. Yes, sir. For video laryngoscope also, and for our direct laryngoscopy also. So whenever we expect any kind of difficult intubation, patient should be put in the ramp position. So this is the most useful maneuver during intubation.
That is for the
rather than all these advanced gadget.
Yeah, continue.
What I want to, sir, mention here, with all these advanced gadgets, the most important thing is the position of the patient, and that is the ramp position. So only 3 pillow works fantastic in any obese patient or in any difficult intubation patient. If we use this 3 pillow and we give the proper ramp position, intubation becomes very easy.
You don't need a video laryngoscope. That is what you are trying to say.
Yes, sir. Absolutely, sir. Since last 1 year, I have not used video laryngoscope in my all intubations. It is completely obsoleted in my practice right now since last 1 year.
Okay, Nilesh.
And
thank you.
Yes, sir. Thank you, sir.
You wanted to say something more?
No, sir. Just what I want to mention, we should use more and more cheaper and what we can get easily in our OT. Like in our OT, we can easily get 3 pillows.
Manuals to
manuals is more important than gadgets.
Okay.
Rather than focusing on more and more gadgets, we should do all simple techniques. It will help in our intubation procedures. Okay, sir. Thank you, sir.
Thank you, Nilesh. Thank you for attending our PG.
Thank you, sir. And yes, sir. And that was a wonderful session, sir. Thank you.
Okay, thank you. Any more questions? Please unmute and talk. If there are no questions, thank the PGs also and Dr. Lini for moderating this session.
Thank you, team, for the opportunity.
Okay, thank you. Dr. Giri, you would like to speak?
I think Dr. Giri is not available.
Okay. Viral, you can.
I just joined. I got late.
Okay. We have almost finished, and like both discussions are over.
I think Dr. Rajesh is there.
No. There are no more discussion. On behalf of Kerala ISA, I thank Madam, Dr. Lynette Madam, for excellent talk, and also the postgraduates from Amala Medical College and the moderator, Dr. Lini. Thank you very much, and thank you all the coordinators, and above all, thank you all the participants for attending in the very good numbers. Thank you very much.